There is absolutely no evidence to support that testosterone levels on therapy should remain within the ranges for endogenous production. That the most consistent benefits with testosterone have actually been with levels that exceeded the normal range.
I still get a lot of comments on this point, men, maybe not in the United States, but internationally in Europe. We can't get the compounded testosterone cream. Can't I just use androgel on my scrotum, for example?
You don't want to use any alcohol-based product on your scrotum. And that leads me into another topic. A lot of guys like to get into the newest, latest, greatest, the most fancy that the pharmaceutical industry can give us. Atrevus. The Atrevus base, it can work great. We've all used it, get great levels with Atrevus. All right. But I had 4 or 5 men that got a significant, irritation from trying that. Atrevus was not designed to apply to your scrotum, by the way.
Yeah.
You can do it. And if you're not one of those guys that has an issue with it, then fine, then it works for you. And so guys that want to use it, I'll let you use the Atrevus base, of course, but be warned. And so just be careful, because you can get good levels, but you can really get great levels with the other bases as well. And you don't run that risk of that significant irritation. And listen, it wasn't a good issue for them. You can't predict when that's going to happen, but they wanted to use it. They used it, and that's what happened. So I've never had that happen with any of the other bases, just Atrevus base. So we don't want to use an alcohol based, and be warned of the Atrevus base. If you can tolerate it, great. You'll probably get wonderful, great levels. But if you're one of those guys that base doesn't work so well with, then you could get some significant irritation, not be happy with it.
Many men also have other concerns, starting on TRT, especially for high hematocrit and prostate cancer. Is there something different between creams and injections on that point?
There's not, Stephen, and I hope that you and I can do another video in the very near future on that's 2 of the testosterone myths: the prostate cancer, and of course the hematocrit. And I'm going to send you something when we finish today that I wrote on the hematocrit and the secondary erythrocytosis. We should do a show just on the secondary erythrocytosis from testosterone. And I just watched a video today, and Dr. Thomas O'Connor did a video on this very topic, and he used literature that is not really literature. It's trash literature. And so still a lot of fear mongering out there about secondary erythrocytosis. And I'll forward you that video as well, to YouTube video. And I'll send you what's not really correct about that video. And we can do another one on that. The prostate cancer, I think there's a fascinating history behind that. And I'd love to tell the story of the Morgenthaler and the androgen saturation model. That's a great story about how it came about, that we learned that testosterone doesn't cause it or worsen it, but instead is protective against it. So I'd love to do a video with you on that to educate your listeners. I like to go back and look at the history of why we've done things, and where that came from. A lot of times when it comes to testosterone, these other hormones, you'll find that the way we've been taught to do things was not actually based on any medical literature or data. It was just an opinion of someone, and it just kept being propagated, not based on any medical data. But the androgen hypothesis on the prostate, that is fascinating, because it's just going to be it'll be a great topic for a video without getting into too much detail on it. But it's a paradox. And what confuses people is the paradox. They know that when men get prostate cancer, they cut off their testosterone levels and the prostate cancer shrinks. But we also know that when we give men testosterone levels, even supraphysiological levels, it has no effect on the prostate or prostate growth. Well, how can that be? That's a paradox.
Yeah.
So I can explain that paradox, and we'll explain that paradox in a video, because I think it's fascinating, very confusing. But once you understand what's going on, then it's a great paradox to understand. All right.
Awesome. Let's do that in a future video very soon.
Yeah. So the next thing that we run into all the time, and I know you do too, is what's happened recently is that the word supraphysiologic has been absolutely hijacked to mean harm and misuse and abuse, or nothing could be further from the truth. Nothing could be further from the truth. So let's talk about testosterone therapy and kind of what's going on with the guidelines and the term supraphysiologic. So, Stephen, most of the guidelines, including the Endocrine Society guideline, recommend that we raise levels to the mid-normal physiologic range, which is around 600.
Yeah.
The normal physiologic range right now, that's that LabCorp that's accepted, is 264 to 916 nanograms per deciliter. Now, the American Urology Association recommends that clinicians use the minimal dosing necessary to drive testosterone levels to the normal physiologic range of 450 to 600. We keep using this word physiologic, meaning that the range that we would naturally produce. Now, the problem is, Stephen, that I don't see many men improving to any significant degree when we aim for the mid-normal range. Now, we've talked about this before, but I can literally show you dozens of studies where men were given testosterone and it did not work. It did not have a significant impact on their symptoms. And the common denominator in all of these studies is that they only raised testosterone levels a little bit. It's very important to point out that there is no medical data that supports treating to a specific number, such as the mid-normal physiologic range. It's an opinion. It was not based and is not based on any medical data showing that if we treat to a level of 450 to 600, that it works better than treating to a higher number. None at all. And more importantly, there is absolutely no evidence to support that testosterone levels on therapy should remain within the ranges for endogenous production. Once again, that recommendation is purely based on an opinion, not on medical data showing that that works best or doesn't work best, okay?
Right.
We've been doing this for decades because that's just the way we were told to do it, and we've really never questioned why. So, so what I have found, as have you, and has many others, our good colleague, Dr. Neil Rouzier, and many others, is that the most consistent benefits with testosterone have actually been with levels that exceeded the normal range, and that the higher levels of testosterone have correlated with a greater clinical effect. We know that, Stephen. We have studies. We see it in the Bayesian dose response studies where men were given 25, 50, 125, 300, 600 milligrams for 20 weeks. And those levels were outside of the normal range and resulted in greater improvement in mood, cognition, libido, and sexual function, as well as a greater increase in lean muscle mass and decrease in fat mass. So we still have to ask ourselves, should we give men what we call a physiologic dose of testosterone, meaning a dose to keep them in that normal physiologic range? Or should we be using a pharmacologic dose like we use insulin for a physiologic effect? Should we be adjusting dosage to treat symptoms, or should we be aiming at a specific number, even though there's no medical data to support aiming for that specific number in the mid-physiologic range? Mm-hmm. I've said this over and over again. Inadequate doses are ineffective, and that if you only give a little bit of testosterone, it either won't work or it'll work just a little bit. So we have to think about this from a clinical standpoint. Could it possibly be, Stephen, that we are more sensitive and responsive to our own production based on the complexity of the physiologic events involved in steroidogenesis? In other words, if you and I could make our own levels naturally of 800, 900, 1,000, I think you and I would feel pretty good, as would most men.
Yeah.
Okay. The problem is when we give testosterone, the end result, we're bypassing all the complex physiologic events involved in steroidogenesis. And there's a lot of intermediate hormones involved that certainly play a role in testosterone's actions. So from a clinical standpoint, we see that we need a level outside of the normal range in most instances to get the same physiologic effect we would get if we produced it ourselves. I hope that makes sense. Yeah. So when we make it endogenously, we probably would do fine with a level of 800, 900. But when we get it exogenously, it takes more than what we can produce physiologically to get the same results. We see this over and over again, clinically and in clinical studies.
Makes sense. Yeah.
So I just think that when we make it ourselves, we're just more responsive to it and sensitive to it than when we get the end result, which is just testosterone.
Yeah. So
we also know that the normal range for testosterone has dropped significantly over the past several decades. Just in July of 2017, it was 1197. After July 2017, it was 916. So now what was normal in June of 2017 is supraphysiologic. So for instance, and people, we can't make this up. So if a man was seeing his physician getting testosterone therapy in 2016 or in June of 2017, and his level was 1190, it was completely normal, nothing red flag. The doctor would pat him on the back. Hey, you look great, Bill. Everything's fine. But then he goes back to that same doctor 2 months later after July 2017. He comes back with 1190 again. Now that doctor is going to lower his dose because now it's harmful, Bill. Your level is 1190 and 916 is the upper end of normal. We need to lower your dose because something bad's going to happen. You're going to have a heart attack, stroke, or a blood clot. You can't make this up, but it's what's happening is what is happening. So there's been this attack on supraphysiologic. When we see from a clinical standpoint, supraphysiologic is what it takes in most men. All right. I didn't say every man. Now, this is all going to be misinterpreted, as you know, as me saying that, well, he's just saying that you just keep raising your levels, and just keep going up, up, and up. More is better. I'm not saying that. I'm saying a couple of things here. I'm going to explain in a little more detail. I'm saying that men, if we follow our guidelines, do not get enough in most instances. I am saying that. Number two, I am saying that it typically takes a number outside of the normal physiologic range in order to exert a good clinical response. We need now to define what is that. So before I do that, let me explain a little more detail. Now, when it comes to the feel-good effects or symptomatic improvement with testosterone, there is a plateau. There's a plateau to the feel-good effects where raising testosterone levels any further will have no further effect on symptomatic improvement. So these men that say, oh, I feel good, I feel great, doc. If I just increase my dose, I might feel greater. No, that's not going to occur. Now, in order to understand the plateau, men need to understand two saturation points: the saturation point of the androgen receptor and enzyme saturation. Now, in order for testosterone and its active metabolites to exert their effects, they must first bind to their receptors. And there is a limited number of receptors available for binding. And once they're fully saturated, then raising levels of testosterone and its active metabolites any further will have no further effect, and it'll just be excess. So we can continue to raise DHT and estradiol, for instance, to a certain point, and we can measure it in the serum, but it doesn't have any clinical effect because the receptors are fully saturated. Now, you know, and I know, and all your doctors that you work with know, that more than half the feel-good effects from testosterone come from its active metabolites, such as estradiol. Now, when we increase levels of testosterone, there's going to be a saturation point of the aromatase enzyme and the 5-alpha reductase enzyme. Once you reach this saturation point, which is referred to the Vmax in Michaelis-Menten kinetics, no matter how much you raise testosterone, you cannot raise estradiol or DHT any further. So this fear of estradiol continually increasing with increasing testosterone dosage is not physiologically possible. There is an enzyme saturation point. So ultimately a plateau. We can raise testosterone levels into the tens of thousands. Dallas Carver, the bodybuilder that died several years ago, he had a level of over 50,000 nanograms per deciliter of testosterone. But his estradiol was no higher than it would have been with a testosterone level of, just say, 1,500 or 2,000, because he had reached the saturation point. Testosterone goes up, DHT and estradiol plateau, and they can't go up any further. So this is what confuses men. It's the misinformation that comes from the bodybuilding world and why they do what they do. Men, first of all, once again, forget that testosterone works through its active metabolites. It doesn't work just as testosterone. Okay, it has a direct pathway where it does work just as testosterone. That's on muscle tissue. But all your other tissues, your brain, your bones, your heart, your blood vessels, your sexual organs, it has to be converted into its active metabolites. And the diversification pathway is when it's converted into estradiol. It diversifies testosterone's actions. And the amplification pathway is where it's converted into DHT. All right.
Yeah.
So bodybuilders use aromatase inhibitors and things like that to increase free testosterone levels, because the way testosterone acts on skeletal muscle is different than the way these active metabolites act in the brain, for instance. So it acts directly on muscle tissue, and with increasing levels of androgens, the androgen receptor is upregulated. So there's no saturation point that we have found yet. And it doesn't require an enzyme to act directly. It just acts as testosterone. So there's no enzyme saturation. So you can continue to increase lean muscle mass, strength, with increasing levels of testosterone and other androgens, even though they will have no further effect on symptomatic improvement. That's an important point to point out. A bodybuilder level of 10 or 20,000 feels no better than you or I do, maybe worse. All right. So the real question, to get back to your original question, to circle back, then what is that saturation point from a clinical standpoint? That's going to depend on who you ask, Stephen. If you were to ask somebody like Peter Attia, who did a video on testosterone, or several of them recently, he will say that when my patients get a level of 700, then if they're not feeling any better, not doing any better, then I'll discontinue testosterone. I would fully disagree.
Yeah, sure. Me too.
So once again, if you were to ask me, where do I see the majority of men significantly improve clinically? It's the free testosterone, around 30 to 60 nanograms per deciliter or so. Those are the levels where I see the greatest improvement in symptoms, and every parameter of health that I can measure improves. So this typically correlates with a total testosterone level, of course, between 1 and 2,000. We said this before. Now, some men are fine with levels less than that. Some men may require a little bit more, depending on that free testosterone level. And so if I have a man that I'm treating and his testosterone level is what we consider optimal, free testosterone level 50 or 60, any symptoms that are left over at that time, once he's given that time to work, I would not associate with testosterone. So my saturation point is going to be upwards of 50 or 60. Once you start getting in that 70s, 80s, well, we're past that saturation point. And if you're not feeling any better, we need to look at other causes or look down other avenues. All right. So that's what I see from a clinical standpoint, and others have done the same thing. We look at some work done by Rebecca Glasser in females. Now this is females now. All right. I mean, she inserted pellets in these women and gave them symptom questionnaires to determine whenever their symptoms of androgen deficiency would develop. And man, what she found out is that these women, when their symptoms resolved, had levels of 300 or 400, which is 4 to 6 times the upper end of the normal range for female. And whenever the pellets were dissolving and they started having their symptoms return, their levels were around 170 or so, which is 2 to 3 times the normal range for women.
Yeah.
So even in women, treating them with exogenous testosterone, it takes a number typically outside the normal range to exert a good clinical effect. Okay, so we should be aiming for symptomatic improvement. That's a boogeyman that does not exist, Stephen. Whenever every parameter, you and I have talked about this before, people will say, well, gosh, they don't, what harm is they're going to be doing long term? Are these men's testosterone being outside the normal range, 1200, whatever?
Yeah.
Well, when every parameter of health that we can measure improves, hemoglobin A1C, inflammatory cytokines go down, visceral fat goes down, waist circumference goes down, lipids improve. When every parameter of health that we can measure improves at those levels, what is the long-term harm of that?
Exactly.
We don't see all those parameters improving with a level of 600. So it appears to me that too low of a dose is going to cause more harm than an optimal dose, of course.
Sure.
So that's my take on what we should be talking about now, is the understanding that the enzyme saturation, androgen receptor saturation, understanding that there is a plateau to the feel-good effects of testosterone. Once you get those levels and you have a consistent level of free testosterone, men need to stop. They could be their own worst enemy. My goal, and I tell my patients, this is my job. I'm going to optimize your hormone, get them as optimal as you can get them. And we're going to be to the point where you're going to have to agree with me that they can't really be any better. We could raise a number, but they really can't be any more optimal. And then you just need to check that box. You need to check the hormone box. And now you need to spend all your rest of your time, not on forums or not, looking to tweak this protocol or that protocol, but instead you check the hormone box. And then you focus on nutrition, you focus on exercise, you focus on your family, you focus on, your wife, your kids, your friends, your hobbies. I'm supposed to do my job to free you up so that you can go live your life without worrying about this every day or ruminating on hormones. And men cannot use hormones like they use a stereo equalizer. You're going to have good days, bad days, good weeks, bad weeks. It's just part of life. Life is not fun all the time. Life is not easy all the time. And you can't address those hard times or stressful situations by thinking you're going to tweak your hormones to get you through it. Every year, I'll get 2 or 3 men that'll call me up, Doc, doesn't work anymore. I feel worse than I did before I started. Now, I used to have a conversation with them first, but now I'll go ahead and get their labs. That's what they want. I've got to get my labs and see what's wrong because it's just not working anymore. Okay, so I'll get their labs. They come back. And Stephen, there's not been one instance that this has not been the case. Not one. So the labs come back. We meet. Well, Bill, I got your levels back. Well, your levels are the same In fact, Bill, they're better. They're either the same or always better than they were when they felt their greatest. I said, Bill, that your levels are identical, or in fact, they're better than they were last time we talked, and you felt great and everything was wonderful. Understand, hormones don't stop working, Stephen. People do, but hormones don't. All right. They don't just all of a sudden lose their effectiveness. They don't. That's not how they work at all. Okay. There's no receptor, burnout, anything like that. That's just rubbish. But so then I'll say, well, Bill, now that we've established that it's not hormones, tell me what else is going on. And these are the answers that I've gotten from all these men. Number one, Doc, my wife had an affair. Doc, I'm getting a divorce. Doc, I lost my job. Doc, I'm working 2 jobs. I'm working myself ragged. Doc, our child was on drugs and now in rehab. And Doc, my mother-in-law moved in who has Alzheimer's, and it's just been terribly stressful. So common denominator is always stress. Stress is the great equalizer. I don't care how great your hormones are. If you're under periods of stress, you're not going to feel as good as when you're not, obviously. And the men that have the hardest time with this, the ones that are typically the hardest to treat, are the guys that are in their early 30s. Life becomes real at that age group. I mean, it just becomes real. You're not really young anymore because you're not in your 20s, but you're definitely not anywhere near old. But you're kind of caught up in that where you've usually got a wife, maybe young children, got a house payment, a car payment, you're establishing a career. That is stressful.
Yeah.
You're not going to feel your greatest all the time, and you can't use hormones to overcome it. All right. So just the key is that there are so many factors that go into how we feel and function every day besides hormones. But once you get your hormones fully optimal, then you should just check that box and move on to every other aspect of your life that you can improve on.
Exactly.
Take home message, Stephen. I'll get off my soapbox now.
Awesome. I guess the home message is that we should try to raise our total testosterone to a certain number, whatever that is. It might be supraphysiological, of course, to have a free T between 30 and 60.
That's correct. For most men, some less, some a little bit more, but that's where, and then you have to give it time to work. This doesn't work in days or weeks. This is months, and then it builds on itself year after year. Yeah. The greatest improvement that I see when a man first starts it is give them 6 to 12 months for sure, and make sure they have optimal levels. And then it works. Improvement will occur year to year as long as the man puts in what I call the sweat equity. You and I have the easy job. We can provide them with hormones and get their levels optimal. They have the difficult job. They have to eat right. They have to exercise. They have to try to get enough sleep and reduce their stress. So they have the hard job. And testosterone won't make any of that easy. Testosterone will reward effort. That's what it does. If you put in the work, you'll be rewarded for that work. It rewards effort, but it won't do it by itself. I think that you've done a good job with everyone that you've had on your podcast. Dave Lee's come around, really done putting out some good content, recently, and because he's, I'm so proud to see that he's telling it like it is, and I'm glad to hear that because that's just the way it should be.